Now, without delaying further, I would like to invite Dr. Devendra Singh to enlighten us about a few words regarding need of this CME and need and vision of this CME and this program.
Thank you, Sithindu. Good afternoon, everyone. These concepts of prevention are not very popular actually, and people do not know who is going to do it. Doctors feel that, well, of course they are busy with the treatment part, why? And other people like the social leaders, the politicians, bureaucrats, they are too busy in doing so many other things. Health is not a high priority subject, at least in our country, in many other countries also. So, interestingly, although the sickness load of liver diseases is rising all across the world, and fatty liver, non-alcoholic fatty liver or metabolic dysfunction associated fatty liver disease is one of the major area where we are going to face a lot of problems. Sickness load of society because of this is going to rise. It's going to rise further and it will be more evident in 3 years, 4 years, 5 years, which is amazing. And there are many such, not a one-off phenomenon, there are many such people. So somewhere something wrong is happening. And as the current generation is facing a lot of precious hours are being taken away by social media indulgence. So the challenges are multifold and they are going to rise, they are not going to come down. With AI coming in, there are going to be new challenges, whether people will stop thinking, stop, having any sort of creativity in their lives. So these challenges are actually so many and multifold that we who have been here for some years and who have been practicing, we have seen, you will agree, Dr. Nanda, Dr. Prabhat Srivastav, Dr. Sujay Mukherjee, Abhijit, that over the years we have change of pattern, we have seen a change of pattern of diseases. Now, what we used to see a couple of decades back are, entirely different. Dr. Sandeep, you will agree with me, because alcoholic liver disease is rising very fast. In our time when we were in colleges, the people used to start drinking when they used to reach college. But now, boys are drinking even in schools. The drinking age now is starting at the school level only. So the years of alcohol consumption, heavy alcohol consumption is going to rise, and it has already risen. And those who are selling alcohol, governments included, they want to sell more alcohol. So where do we place ourselves in this entire complex scenario where more alcohol is coming to people, they are consuming more, and they are falling sick in a worse manner. What we see many times, the alcoholic liver disease patients come in such a bad shape that you can hardly do anything. The way more and more people are going to require transplant, which again is a very precarious scenario. The number of transplants required in the country, I think less than 5-7% are getting transplanted. That means a lot of people are dying in that stage where they are unable to either afford, get a liver, and logistics are not there everywhere. So because of all these complex situations, what we feel that a better way to approach is to arouse people's interest towards prevention, to moderate their behavior, to improve their physical activity part, to moderate their drinking habits, and who else can tell these things better than us ourselves. So I thought let's have a preventive hepatology CME where this is not a long CME, we have chosen just few topics and just a 1 hour CME, but this is something, it's kind of a pilot project for us so that we can take it further. We may make it an annual affair. We may take it to other cities also of Chhattisgarh, and let's see how it goes on across the day. In the morning we had the lifestyle session, the lifestyle which we promote, like increased physical activity, yoga, meditation, aerobics. These are things which are useful in reversal of metabolic syndrome. So we had sessions on that, and thereafter to arouse interest among the children, because children are the ones who are required to be sensitized about ill effects of addictions. So we had a painting competition among the school children, and a good number of them participated, and we are going to award them also in the evening time. And then to educate the lay people in a very simple pictorial way, we are going to demonstrate them how alcoholism proceeds to liver cirrhosis, how fatty liver disease proceeds to liver cirrhosis, and how viral infections proceed to liver disease, advanced liver disease. They are very simple posters, not meant for doctors actually, they are meant for lay people, so that they understand and they at least grasp something that these things are bad and at what level they can reverse these things so that the sickness burden of the society because of these things comes down. So this is a very humble attempt from our side, and we feel that if this is received well by the people, we may have, we will be motivated enough to hold it on an annual fashion. With these few words, I think we have got fantastic speakers today, led by Dr. Sandeep Pandey, who is a very dear friend and eminent gastroenterologist from Raipur, Ramakrishna Care Hospital. Then we have our birthday boy, Dr. Avijit Rayazada, and he's a local senior physician, and Dr. Paramez, who has taken pains and he has come all the way from Hyderabad to talk about liver transplant, and he's from Apollo Hyderabad, and he is also with us. With these few words, I think we should start the proceedings. Thank you.
Thank you, Singh sir, for enlightening us regarding importance of prevention of disease, because prevention is always better than cure. It's without delaying, Dr. Avijit Rayazada for first talk of this CME. The topic is strategies for NFLD and obesity prevention. Chairperson for this session will be Dr. Manoj Rai, Dr. Vijay Srivas, and Dr. Vineet Srivastava. I would like to Dr. Avijit Rayazada, sir, please.
Hello. Related to heart, that is what actually the liver is father of all organ. You may not be agreed, but all the functions, all the metabolism, all the work, we have got a transplant surgeon also, sir is also there, but still the topic of prevention is the key, that is the funda behind the first liver carnival. And I'm not expert of fatty liver or NFLD, so I'll focus more and more on prevention part, because as per my understanding, if you say retinopathy grade 0 is preventable, diastolic dysfunction, that is called heart failure grade 0 or grade 1, is totally preventable. Fatty liver, that we can detect by only by definition, because of they are doing swimming, they are using more and more less fat type of diet, they are taking omega-3 fatty acid, but we are behind. We are 70% of our diet is carbohydrate. That is the reason. This is very important. Twin cycle hypothesis, etiology of type 2 diabetes. Why I am connecting with the diabetes? Because they are connected to hypertension, heart failure and AMI. So whenever we talk about NFLD, one cycle goes to diabetes and another goes to the heart failure and AMI. So my particular attention is that whenever we are treating 11 crore diabetes, maybe in next 5 years it will be 22 crores. Why not to start exercise? Why not to change the diet to low fat, low carbohydrate and good protein and a high fiber diet? And most important, activity in the primary school, as Dr. Devendra sir has rightly said, make a 2-hour session of outdoor game. Particularly in Australia, they have banned 12 years, no social media. In China and Japan also, they have banned below 9 years. So stop mobile and social media. It is a crime to provide a social media platform to our kids. Next slide, please. And this is the direct intervention. This is very, very important. Every mother and teacher must know what is the diet replacement, what is the nutritionally complete, how much must be the calorie, what should be the standard carbohydrate. We have to reduce to 30% in a growing child, and we have to double the protein so that our height and weight will be there. Surprisingly, China, Japan and Korea, they have increased their total height and they are maintaining very good weight loss because of this unique type of diet. And visit 2 to 4 weekly at primary care center, which is very, very important. Our school program, we are providing 9 things in every party, every birthday. Rather than providing a healthy, we are giving all the junk food that is full of calorie, bad fat. That is very, very bad for future fatty liver. Next slide, please. And this is a very, very important. When selling policy, this is the gesture, and when there is outcome, this is the outcome. Calorie loan received in childhood is ultimately a death sentence which is provided by their unique aunties, relatives and neighbors. So whenever you are giving a birthday party, give with the salad, low calorie food, and no junk food should be allowed to any school or any birthday party. That is the very important message. Next slide please. And this is the Diabetes, International Diabetes Federation, they have given these guidelines. Why I am saying diabetes every time? Because all the fatty liver, NAFLD, they are going to almost 30%, they are going to become pre-diabetes. And they may lead in next 5 years to cardiovascular disease, kidney failure, blindness and lower limb amputation. These are the alarming features. 50 to 80% of people, their diabetes die of cardiovascular disease. 44% of new kidney failure cases are observed in diabetes. Again, pre-diabetes, they are albuminuria, they are diastolic dysfunction, and 1/3 of them, they are going to die of heart failure in next 10 years. 60% of the non-traumatic amputation, those who are not doing cycling exercise and they are having pre-diabetes and uncontrolled dyslipidemia. 16% of people more than 65 years with diabetes, they die of a stroke.
Epidemic of obesity. So, of course, the society is gradually maybe sensitizing after COVID, but we are seeing a lot of activity, awareness about
The trend of death in they will be sitting there only doing nothing. This is middle class doing nothing also. Lethargy is the major reason. Diet is same in last 50 or 60 years apart from the junk
basically
food.
the attack on obesity has to be multifold.
Yes, sir.
Education is one, the corporate, so everybody has to pitch in for this actual burden to come down.
I will thank Dr. Ashish Jaswal. He created awareness of cycling for 7 or 8 years back. So that has changed the life of very many doctors. Yes. Thank you, sir.
Sir, is there any pharmacological means to prevent this NAFLD?
That is the grey area, because a lot of work about pioglitazone, metformin, sir must be convinced, saroglitazar, they all are very effective, but they are very temporary. Basic is the exercise, A, B, C, alcohol, anxiety must be banned, BD cigarette should be stopped, junk food should be avoided. Almost 65% work is done. Taking alcohol with smoking, they are going to die, not because of fatty liver. This is not so dangerous. This is just opening. It is the tip of iceberg, 90% is below. That is what is our motto is. Stop it now. Drugs are there. Saroglitazar is there. GLP analog is very promising, but that is for diabetes and cardiac mortality. They have prevented a lot of things, but it is very costly. Not for a country like 150 crore, where only 3 crore population they are paying tax and 9 crore only are covered by insurance. So very costly, at present out of reach of most of the population. Prevention is the key.
Just like to add something, like fatty liver, they are more likely to die of other cardiometabolic diseases.
Yes, sir.
But those who have F3 to F4, they are more likely to die of liver-related illnesses.
Yes.
So we need to do a further analysis. Those who have those who have comorbidities and are having high FIB4, the cutoff is different. It's not 2.7 anymore. Even much lower is
very informative,
nowadays,
sir.
yeah.
I want to add one more thing. Once you are saying 0 to 2, they are having simultaneously retinopathy, BP of 135/85, albuminuria, important because diastolic dysfunction, they are going to become heart failure after 5 years. Albuminuria, they are going to become CKD after 10 years. All the retinopathy, they are going to make the patient blind. So pre-diabetes and its complication in 0 to 2, as sir has correctly said, and 3, 4 will all go to liver transplant.
This great interactive session. For the next topic, I would like to call upon Dr. Sandeep Pandey, and his topic will be preventive strategies for ALD. For this session, chairpersons will be Dr. CHHATISGARH and Dr. Lajpat Agrawal. Please.
Good afternoon, everyone. First of all, congratulations to Dr. Devin Singh and his team for organizing such a fantastic event, or rather series of events meant for society. And this must have been a tough task, organizing so many events, interacting with so many people. So hats off to him and for his team. And lastly, I am thankful for making me a part of this constructive awareness program. I'll be talking on management of alcoholic use disorder in alcohol-related liver disease. So this slide shows the magnitude of the problem. The alcohol use causes 3 million deaths worldwide, and 10% of all deaths is attributable to alcohol consumption. And thousands of people die every day from alcohol attributable causes. This is a recent meta-analysis which shows the global burden of alcohol-related diseases. And India also constitutes a good chunk. About 10 to 11% of our population are indulged in alcohol use. So the worldwide prevalence is about 5%, predominantly males, around 3%, and females, about 0.5%. And liver-related mortality is about 20%. Now coming on to alcohol use disorder in hepatology clinical practice. Alcohol use disorder, it is a new term. Previously it was known as alcohol dependence, but because of the stigma attached to the terminology, this has been changed to alcohol use disorder. So now these are the presentations. This is how patient can present to us, like in OPD with a raised SGOT, SGPT, mild hepatitis or stable cirrhosis. In indoor patients, they can come as alcohol withdrawal syndrome or subacute hepatic failure or ACLF, and again they can come back to OPD after discharge. So let's start with IPD patients group, withdrawal syndrome. Alcohol, there is a imbalance between neurotransmitters. Basically GABAergic transmission and glutamatergic transmissions, they form in alcohol abuse. And in case of withdrawal,
PBS, PSC, and secondary biliary cirrhosis, biliary atresia, and we see mainly biliary atresia in case of pediatric patients, and other genetic abnormalities are next cause for all those things. And we have done a few cases of adult polycystic kidney disease. Sometimes they usually present at the age of 40 to 45. They present with a massive liver and massive spleen, massive kidney. So both liver and kidney will be in a sort of failure status. And we have done 2 cases of adult, both combined liver and kidney disease, kidney transplant. So both have survived and they are doing well. And other diseases like sarcoidosis, amyloidosis, and sometimes more very rarely for a hepatic trauma also they may require liver transplant. So coming to the acute liver failure, so there can be several causes of acute liver failure. It can be an Wilson disease, or it can be an alcoholic, or it can be viral hepatitis infection. Most of the Hep A and Hep A are self-resolving and they very rarely require a transplant. But other viral hepatitis, definitely they can go for a acute liver failure. So acute liver failure, based on King's College criteria, we categorize and we enlist them for the urgent emergency liver transplant. So the main contraindication for liver transplant are severe cardiopulmonary diseases, extrahepatic diseases, extrahepatic malignancy, or active alcoholic substance abuse, and even active infection, uncontrolled sepsis, a lack of psychological support, or in case of brain death patients, so it's totally contraindicated. And relative contraindications are advancing age and sometimes HIV also. And in cholangiocarcinoma, most of the cases we do transplant, but in early stage, less than 2 centimeter with a strict chemoradiation. We select a criteria for that, and we do transplant in cholangio. And HCC is more common when compared to other things. So for each and every patient, we need assess clinically and educate both family and patient, and we need to decide on transplant, and we need to counsel them. So this is the assessment chart. So these are the investigations to be done before transplant. So this is a pediatric list of investigations to be done. So before transplant, each and every patient, we have to manage their medical conditions like ascites, management of portal hypertension. If he's bleeding, or if he's having a high risk varices, we need to band them, and we need to preserve the renal function, and hepatic encephalopathy, other things we have to treat. And if, for example, if he has an infection, he is a different from normal patient. So we have to take care of these patients until they undergo liver transplant. So coming to the transplant phase, we need to assess the donor. So assessment, it can be cadaveric assessment, or even living donor also. People, we need to assess. So living donor, it's a totally different protocol. So we need to evaluate with all the medical history and medical investigations, and we need to counsel, and we need to take clearance of psychiatry department also. And whereas cadaveric, this thing, mainly the consent from the family is important. So if they give consent, we can go ahead with, we have to do all the blood tests. If the liver is good, quality of liver also matters. All these things we need to evaluate and before going for a transplant. So especially in the cadaveric donor, we need to address asystole. For example, most of the patients will be in brain death. They will have a cardiac arrest also. We need to revive them, and we need to monitor the pressures also. And we need to take care of hypernatremia. Electrolyte disturbance is more important. If the sodium level more than 150, it stays for more than 6 hours, it will cause a primary non-function of the graft. It can be liver also. Liver can fail. So complete, this is almost, sometimes we have to go for 500 kilometers or 700 kilometers to harvest an organ and to implant in a patient. So coming to cadaveric transplant, so this is how the cirrhotic liver looks, and this is how the new liver looks. So this is a complete picture of transplant. So this is a cirrhotic. First we will go into do a recipient hepatectomy, that is full liver, cirrhotic liver has to be taken out, and we have to secure the hemostasis, and we have to control the bleeding, and then we have to go for an implantation. So we need to implant so first we have to secure the hepatic venous outflow. So IVC anastomosis will be the first thing, and next is portal anastomosis. After that we will do reperfuse the organ. Once the reperfusing of the organ occurs, then we have to go for hepatic artery and bile duct reconstruction. So this is how after reperfusion the new liver looks. So this is a hepatic artery anastomosis and common bile duct anastomosis. So coming to the split liver transplant, so in most of the cases, if the liver is good, the liver is young, we split the liver. It can be done in on table or it can be in ex situ also. So we split the liver into two parts, right lobe and left lobe, and we implant into different patients. Right lobe will go for a slightly adult patient, and left lobe will go for a slightly low weight, that is in case of kids or a low weight around 30-45 kg adult, it will go. So this can be done. So especially in living donors, there should not be any conflict of interest, and there should not be any coercion. So only family members, grade 1 and grade 2 family members can donate the liver to a allowed person, whereas other, for example, friend if he is donating, or any other person if he is donating, he has to get clearances from the court, and they have to, it has to be certified by the district or a state medical council. So the main criteria for donation is liver should be good, and steatosis should be less, and quality of liver should be good. That's the main thing. So this is how we assess the living donor. So we have to assess, should have a clear idea of about hepatic veins, portal vein anatomy, and hepatic artery and bile duct anatomy. So each and everything we going to calculate. So by using a CT volumetry, it's a computer based imaging. So each and 1 cc of liver also it will be calculated. So based on that we proceed for the, we keeping a good remnant in the donor, and we take out the other portion of the liver. So for example, right lobe we are taking, so this is how the right lobe is marked, and we are going to take that. So these are the steps of liver transplant. So first right hepatic artery and hilar dissection has to be done. After that we will go for a transection of the liver, and this is how we harvest the liver. So after this is after completion of right lobe removal. So we on table we perfuse with a cold saline. So cold saline or a cold preservation is so in order to keep the tissue alive, so we decrease the temperature of the organ by up to 4 degrees centigrade, and so that all the metabolism is there, it will come down, and when we implant it will restart its working. So if we keep in warm temperature, the tissues, the degradation of the tissue or death of the tissue will occur very fastly. It can be within it can be 1 hour or 2 hours. That's why we store in cool saline and then we implant into the human body. So this is how we implant. This is a caval reconstruction, right hepatic vein, and this is portal vein reconstruction, and this is arterial and bile duct reconstruction. This is coming to the pediatric liver transplant. So the most commonest cause is adult biliary atresia. It accounts for about 52%, and the metabolic diseases around 26%, and acute hepatic necrosis around 16%. All other genetic causes can be very less percentage. Usually we prefer a left lateral lobe based on the weight of the patient. So this is how the left lobe of the donor is harvested, and this is how we connect to different vessels. So these are the few things we have done. So the post surgery, mainly we need to take care of primary non-function. So we need to tackle all these complications. For example, this is very rare, but it can happen. Hepatic artery thrombosis or bile duct stricture, or even rejection can happen if the patient is not following up properly. So they are more prone to more of opportunistic infection also. So we usually up to 3 months we give antivirals, that is usually valin cyclovir. So in order to cover prophylactic and antiviral therapy, and pneumocystis carinii is also one of the commonest infection, and we also give prophylactic drugs for that. And first 3 months is important. So we have to take care of the patient with maximum care. After that, definitely patients they themselves they can monitor. So main important thing is education, medication, and infection control. So coming to the survival, so most of the transplants will have 1 year survival of 90 to 95%. So and 5 year survival of 80 to 85%, and 10 year survival of around 75 to 80%. So this is almost this is after